We will speak about onychomycosis. The word onyx means nail and myx meaning fungus. Therefore, onychomycosis is fungal infection of the nail, and it may be caused by any fungus, dermatophyte, non-dermatophytic molds, also candida. And tinea anguum is specifically dermatophytic infection of the nail. And nail infections may be the sole manifestation of fungal disease in a person, or it may also be associated with tinea pedis or tinea manum, pedis being foot and manum being palm. And it is more common in children than in adults. It is due to the faster growth of nail in children. The nail outgrows the fungus, and that is why uh, it's lesser seen in adults. Also, that is the speed of the growth. It is the reason why it's more common in toenails than in fingernails, because the fingernails grow faster. Coming to risk factors, as we can see, it's more common in men, it's more common in toenails, and it is caused by occlusion. In these women, they wear this pointed covered shoes and all, and repeated trauma, old age, immunosuppression, smoking, poor peripheral circulation, then associated tinea pedis, also other skin diseases involving the nail like psoriasis, then lichen planus, etc. And these are the causative agents. In dermatophytes, it's caused mainly by trichophyton rubrum, also trichophyton interdigital. In non-dermatophytic molds, it may be caused by Aspergillus, acrimonium, fusarium, also candida. And these are the 5 types: DLSO, WSO, PSO, endonyx, and TDO. And we'll come in to the specific types. And these are the images of the 5 types. Distal lateral subfungal onychomycosis involving the distal and the nail plate proximal to the lateral nail folds, while superficial onychomycosis involves the dorsal nail plate, and it may be seen as white patches over the dorsal nail plate. Then coming to proximal subfungal onychomycosis, then endonyx, then finally total dystrophic onychomycosis. Now we will come to DLSO, that is distal lateral subungual onychomycosis. It is most commonly caused by Trichophyton rubrum, and it starts by invasion. The fungus invades through the stratum corneum of the hypoonychium. As we can see in the image, hypoonychium. Uh, it's the area between this distal nail fold of the nail bed and the distal nail plate, distal free end of the nail plate. And the infection moves proximally in the nail bed and invades the ventral surface of the nail plate. And this is the image showing the DLSO. And there is a hyperproliferative reaction to the fungal infection. As there is an infection, there is a hyperproliferation which causes subungual hyperkeratosis, and also there is a discoloration of the nail plate. While in non-dermatophytic infection, the difference will be there is marked periangular inflammation, similar to acute paronychia. There will be erythema, edema, tenderness over the proximal and lateral nail folds. Finally, it progresses into total dystrophic uh, onychomycosis. Coming to white superficial onychomycosis, it is the second most common type and most commonly due to trichophyton interdigital. It is seen as well circumscribed powdery white patches away from the free edge of the nail. It is seen as superficial white patches, and it should be differentiated from other causes of leukonychia. It can be differentiated by scraping, and due to the powdery nature of the white material, it can be scraped away, while in leukonychia it cannot be. It will be there even after scraping, and the surface of the nail is rough and friable. And this here is WSO. As we can see, it is little bit distant from the distal nail plate. And coming to PSO, that is proximal subungual onychomycosis. It is the least common type, and it is an early indicator of HIV infection, most commonly by Trichophyton rubrum, just like DLSO. Others, interdigital, then tonsurens, and it's seen as a whitish to brownish area on the proximal part of the nail plate, and this area gradually enlarges to affect the entire nail. Initially, it affects the proximal part. Here, it's the proximal part. This is the distal part. This is the dorsal part of the nail plate. While inside, it's the ventral nail plate. The nail plate is having dorsal, intermediate, and ventral parts. And the organisms invade the ventral surface of the nail plate from the proximal nail fold. As we can see, the proximal nail plate is involved. Coming to the endonyx type, it is an uncommon type, and invasion of the nail plate, it starts from the distal free edge, just like DLSO. But instead, like in DLSO, instead of infecting the nail bed, doesn't infect the nail bed like DLSO. The fungus penetrates the distal nail keratin on the of the nail plate, and thus the nail plate is scarred with pits, lamellar splits, and invasion occurs from the top surface, but it penetrates deeply into the nail plate, and milky white patches are seen without subungual hyperkeratosis or onychomycosis that we see in DLSO. It's caused by Trichophyton sudanens, also Trichophyton rubrum. Coming to total dystrophic onychomycosis, this can be seen as the end stage in untreated DLSO or PSO, and visually we can see the nail plate is diffusely thickened, friable, and discolored. Coming to candidal onychomycosis, um, in comparison to this dermatophytic onychomycosis, it is associated with paronychia. There is inflammation, erythema, edema, tenderness uh, in the proximal and the lateral nail folds. This is an image of the patterns of infection. As we can see here, for proximal subungual onychomycosis, there is infection from the proximal side, while white superficial onychomycosis and distal subungual onychomycosis, it enters distally. Dermatophytoma can be asked as a question in viva. It is a circumscribed, dense fungal mass formed within and under the nail plate. It is seen under the nail plate. This you see is the nail plate. It is seen under the nail plate and forms a biofilm. This biofilm is important because uh, this biofilm prevents it from getting affected by antifungals, and it appears as a linear single or a few white or yellow bands on the nail plate, and they are formed due to fungal mass firmly attached to the nail plate and produce an extracellular polysaccharide. And uh, in these cases, pharmacological and surgical therapy is recommended. These are the different DEDs. Yeah, most common it may be psoriasis. In psoriasis, there is pitting. Then other skin lesions will be present. Lichen planus. In lichen planus, the most common nail finding is, of course, thinning due to the repeated itching, and of course, skin lesions will be seen. Then others include onychogryphosis, pachyonychia congenita, then diarrhea syndrome. Always we should rule out melanoma. Diagnosis, it's by KOH examination and also fungal culture on mainly on SDA. And while taking the specimen, the entire nail should be thoroughly cleaned with alcohol first. Then the affected nail bed should be exposed by removing the onycholytic nail plate with a nail clipper, and we should scrape the nail bed with scalpel or something, and the outermost debris must be discarded, and Sample of the distal nail plate should be avoided as it frequently contains contaminants. And this is an image given in the Elsevier clinical dermatology. While for KH we should always take out the subungual debris, not the most distal but a little proximal. And for culture, both the subungual debris and the nail clipping can be used. And in KH examination, as we can see, fungal hyphae can be elicited, and these are there are some diagnostic principles. If a dermatophyte is isolated in culture, it is always considered a pathogen, and if a non-dermatophyte mold or yeast is obtained in culture, it is considered significant only if its hyphae or yeast cells are seen in microscopy. And if there is repeated heavy growth of a non-dermatophyte mold without concurrent isolation of a dermatophyte, it is considered as onychomycosis caused by a non-dermatophyte. And dermoscopy, of course, it can be used as uh, an adjuvant to this findings. Of course, it's a non-invasive technique. And this I have taken these images from a journal, and it shows the first image shows a ruin appearance of the proximal nail plate. It may be due to the subungual hyperkeratosis. Also, in second image we can see there is longitudinal striae, longitudinal linear striae. Also, we can see transverse leukonychia. In IADVL, these are the four findings. It's given: longitudinal striae, jagged proximal edges, intermittent spikes we can see it here, and smooth linear termination. Now we go on to the treatment. In the treatment part, there is topical as well as systemic therapy. Topical therapy, it's indicated when there is distal nail involvement and in white superficial onychomycosis. Also, when there is a contraindication for systemic treatment, that we'll see in further. And these are the main topical agents: amorolfin 5% nail lacquer, cycloperox 8% nail lacquer. Only these two are available in India. This efinaconazole, also recently 5% uniconazole lotion is available, but efinaconazole and tavobarol, it's not available in India now. And amorolfin and cycloperox are the most commonly used. 5% amorolfin, it should be applied once or twice weekly for a period of 6 to 12 months. Cycloperox, while it's applied daily for 6 to 12 months. Also, chemical avulsion of the nail can be done using 30% salicylic acid, 50% potassium iodide, and 40% urea. It's given under occlusion. Coming to systemic agents, when multiple nails are affected, also when more than 50% of the nail is affected, lunula or matrix is involved, also when the patient is immunosuppressed. Terbinafine is more effective in continuous method rather than pulse. It is given as 250 mg OD for fingernails 6 weeks and toenails 12 weeks. And it is the most effective drug for onychomycosis. While terbinafine can also be given as pulse, continuous is always preferred. In pulse, it is given as 500 mg per day for 1 week per month into 3 months. Coming to itraconazole, itraconazole is given as pulse 200 mg BD for 1 week per month, and for fingernails 2 months, toenails 3 months. That is, for fingernails 2 pulses are given, while for toenails 3 pulses are given. And continuous itraconazole is not preferred. 200 mg OD for 6 to 12 months. Sorry, for 6 to 12 weeks. And oral fluconazole and griseofulvin are not that effective. Some newer modalities like Q-switch Tendiag or long pulse Tendiag or fractional CO2 have been tried out along with topical antifungals. And these minimally invasive devices have been considered as newer modalities, and it has not been approved as a separate treatment modality, but it is being tried out. And it may be due to this absorption energy by fungal xanthomycin and melanin. And it also causes local erythema, destruction of the fungal agents, and repair. And a combination therapy is always preferred, that is combination of oral and topical antifungals simultaneously or in sequence. And the main combinations include amorolfin or cyclopyrox with crizofelvin, terbinafine or itraconazole, with or without surgical measures. Because it's used because drug penetration may be suboptimal in the lateral borders of the nail with oral therapy, while topical therapies may not penetrate the deeper layers of the nail. So, when we give oral plus topical, the oral drug will have high concentrations in the nail bed, while the topical therapies can penetrate into the deeper layers of the nail, also through the lateral nail folds. And this is another thing that can be asked in your viva. This boosted oral antifungal treatment or BOT, and to target the dormant chlamydospores and anthraconidia within the nail plate. In this, we keep a piece of SD agar onto the affected nail plate for 48 hours following the weekly pulse of itraconazole, and thereby the penetration is much higher. Also, surgical management surgery can debulk the keratinized material by debridement or curettage. Also, in the cases of dermatophytoma. This is the overall view of the types of onychomycosis: DLSO, WSO, PSO, and endonyx. And TDO, or a total dystrophic onychomycosis, it's the end stage where there is crumbling and destruction of the nail plate. And as we can see, there is etiology and there is difference in portal of entry and in clinical features. So I think this video has been helpful for you, and I'm taking this video as a part of my learning process, and also if some people find it useful, I'll feel much obliged. Thank you. Happy learning.